Assalamu alaikum, Dr. Altaf.
Assalamu alaikum, Asad. Welcome, Nadeem Tehami. How are you?
And Nadeem, are you with us?
Assalamu alaikum. जी अस्सलाम वालेकुम.
कैसे हैं आप? ठीक ठाक हैं?
जी सर अल्हम्दुलिल्लाह. आप कैसे?
तो मल्टीटास्किंग तो नहीं कर रहे इस वक्त?
नहीं अल्ताफ आलम साहब का मैंने नाम देखा, मैंने कहा केस डिस्कशन है तो लेट्स गो एंड लर्न समथिंग फ्रॉम द गुरु.
Thank you, Nadeem. You don't need me to teach you anything.
नहीं sir, honestly I wish I genuinely mean it. There's loads that I can learn from you.
I think we should wait for another 3 to 5 minutes to see.
जी sure.
नदीम, आपका मौसम कैसा है? इधर तो बहुत मशहूरी हुई हुई है आपके मौसम की वजह से.
जी बिल्कुल, थोड़ा सा मौसम गर्म है लेकिन अल्हम्दुलिल्लाह शुक्र अल्लाह का. It's a nice weather.
अस्सलाम वालेकुम. आसिफ, कैसे हैं आप?
जी सर अस्सलाम वालेकुम. कैसे हैं आप? ठीक ठाक हैं?
बस ठीक ठाक हैं. गुड टू सी यू. आपको हमने रेगुलरली देखना चाहते हैं.
ऑलराइट सर, आई विल बी इंशाल्लाह. मैं अभी वो बस डॉक्टर नदीम का जो है ना वो मैसेज उसमें देखा पीएसएच में, तो एकदम से फिर मैंने कहा कि ये तो अपॉर्चुनिटी मिस करना बड़ा गलत हो जाएगा. और अल्ताफ साहब की लेक्चर तो कभी नहीं मिस किया हमने. हो जाते हैं यहाँ पे.
इस दफा लेक्चर नहीं है, इस दफा जो है ना हम आपके साथ डिस्कशन करना चाहेंगे.
ऑलराइट ठीक हो गया सर.
थैंक यू वेरी मच.
थैंक यू.
Once we are waiting for 1 or 2 more minutes before we make a start. Altaf Sahab is here. Nadeem Tehami is also here.
Alright. Assalamu alaikum to everyone. Assalamu alaikum.
Assalamu alaikum. On behalf of Psycho Pakistan, I would like to welcome all of you to this case-based discussion, which is held now on monthly basis. And today we have Professor Altaf Alam as an expert with us, who needs no introduction. And also we have I would say, some stars of gastroenterology and hepatology with us. So it's going to be a very interesting session, inshallah. So मेरे ख्याल में we can make a start, क्योंकि we would like to finish within time. Uzair, if you can share the screen, you start with case number 2, your 008 hai. Dr. Zishan is here also, and we open discussion on that. So if you can, जी इसको थोड़ा सा बड़ा कर दें, ये इसको जरा enlarge करें fonts को, जितना maximum आप इस अपनी स्क्रीन पे कर सकते हैं, इसको मैग्नीफाई करें जरा.
Sir, wait a moment, I'm doing it.
ये वर्ड पे होती नहीं इसमें, ये आपकी, हाँ थोड़ा सा और इसको बड़ा कर दो अगर होता है. ओके जी, ठीक है, ठीक है. So this case, I'll just go through some very quickly, or I will like Dr. Zishan to chip in, and then we'll take Professor Altaf on board. So basically, we have this case or query from Karachi. This is a 45 years old gentleman, known case of end-stage renal disease secondary to obstructive uropathy, and being planned for maintenance hemodialysis. So he was diagnosed as hepatitis B reactive, 10-year negative. Current hepatitis workup shows hepatitis B surface antigen negative, but hepatitis B core antibody. We'll be discussing how we proceed on this case. Dr. Zishan, you would like to add something here?
Yes, thank you, Asad. This was one of the query posted to me by nephrology department recently. This case was treated 10 years back for hepatitis B, and he took entecavir for 2 years, and then he was lost to follow-up. He did not follow. He just presented to nephrology, where on workup he was found to be, as with the history, he was hepatitis B. They worked it on him up, and they found surface antigen this time was negative, but the core antibody was positive, PCR negative with normal LFTs. So they were dialysis. Now, dialysis practices in public sector hospitals are there. Most of these patients actually they reuse the dialyzer set. They don't reuse dialyzer set for different patients. One dialyzer set is restricted to one patient, but the problem is their storage. I'm sorry, I was offline. There was a call, probably I got offline. So the problem they had was they were storing the dialyzer set in one refrigerator, and they were worried about that would there be a risk of transmission to other patient, or we should throw off every dialysis with this patient. But that's what the question was, can we dialyze in the same? Still they separately dialyze on different machines, and the BC negative patients are dialyzed on in separate machines. So
जी ज़ीशान, ये मैं थोड़ा सा क्लैरिफिकेशन चाहूंगा. आप ये कह रही हैं कि जो डायलाइजर सेट है वो रेफ्रिजरेट उसमें स्टोर होता है, ये तो डिस्पोजेबल नहीं है. You know, usually one time वो जो which I understand is वो जो ट्यूबिंग है जो आगे लगती है.
स्टैंडर्ड प्रैक्टिसेस यही होती हैं कि डायलाइजर सेट आफ्टर एवरी डायलिसिस जो होता है वो डिस्पोज कर दिया जाता है. बट फॉर द कॉस्ट कटिंग मेजर व्हाट दे डू इज के 2 या 3 डायलिसिस बड़े आराम से एक डायलाइजर सेट से ये लोग कर लेते हैं जब तक कि वो ब्लॉक होना नहीं शुरू होता. तो दैट्स व्हाट देयर प्रैक्टिस इज इन द
and the dialysis रेफ्रिजरेटर जिसमें और भी फिर होंगे, I would understand,
वो
stack हुए हों।
वो पुल अप करते हैं पेशेंट का नाम लिख के और उसके एमआर वगैरह जो भी उनका रजिस्ट्रेशन सिस्टम है, कि जब मरीज नेक्स्ट प्लेट पे आता है तो उसका डायलाइजर निकाल के उसको रीयूज कर लेते हैं, अनलेस कि वो ब्लॉक हुआ हो तो फिर वो चेंज करते हैं। वो इसी तरह से जिस तरह से इंसुलिन सिरिंजेस हैं, है वो इंसुलिन सिरिंज आप पेन करती है तो लोग फेंकते हैं, वरना कंपनी तो रिकमेंड करती है कि एवरी टाइम आप नई सिरिंज यूज करें। सो ऑन एन एवरेज वो ये कहते हैं कि ये हम 2 से 3 डायलिसिस एक डायलिसिस सेट से मैनेज कर लेते हैं, तो दैट डायलिसिस जो मेंटेनेंस कॉस्ट है वो काफी कम हो जाती है उनकी।
दिस विल बी अनदर डिस्कशन मेरे ख्याल में, बट बहरहाल अभी मैं अल्ताफ साहब के पास जाऊंगा। अल्ताफ साहब इसके बारे में क्या कहते हैं? जी जी सर, ओवर टू यू।
Well, there is no concept of hepatitis B positive and that a patient is, when he's put on dialysis machine, everything is disposed of except the machine itself. But this is a very bad practice in 2022, that you are reusing the dialysis set on maybe the same patient repeatedly, maybe 2-3 times. This is a bad practice. How does B and C virus spread in the dialysis room? It spreads through you and me. This is a place where there is a lot of blood. The fistula, when it is needled, there is some blood everywhere. So it spreads through our fingers and other equipment like the blood pressure apparatus, etc., from one patient to the other. If we are careful, this should not happen. And if the disposable set is disposed of after each dialysis. So this is how it spreads, and this is because of these bad practices. We have published data from Pakistan that, you know, something like 60% plus patients on dialysis are either B or C positive. Now, coming to this patient with or without treatment has achieved what we call a functional cure. Let me first define the cures that occur. Normally, what we achieve in hepatitis B with all these drugs, nukes, चाहे वो एंटीकावेर हो, चाहे वो टेनोफोवेर हो, चाहे वो टेनोफोवेर एलाफिनामाइड हो, what we achieve is what we call partial cure. What does this mean? DNA becomes negative, ALT usually normalizes, surface antigen is still positive, and E antigen is negative. I must also add that in these patients with partial cure, cccDNA and integrated DNA is still present in the patient. What we mean by functional cure is DNA negative, E antigen negative, surface antigen negative, with or without appearance of NTHBS. Not talking about NTHBC, it will remain positive for the rest of patient's life. NTHBS may appear or may not appear. That does not make any difference. If you have the sophisticated tests, you will find that cccDNA is still present but inactive. So surface antigen is a bad surrogate marker of cccDNA within the hepatocyte. So the cccDNA is present but inactive. And if you check for integrated DNA, which is the DNA of hepatitis B integrated into the genome of the host genome that is still present. Then there is another term called complete cure or sterilizing cure. This is where surface antigen is negative, DNA is negative, anti-HBs may or may not be positive, cccDNA is negative, and integrated DNA is negative. So this is what we call complete or sterilizing cure. So according to these definitions, this patient has what we call functional cure. Surface antigen has become negative, and if we investigate, E antigen will be negative and DNA will be negative. There is another condition called occult hepatitis B where DNA may be present. So let's not talk about that yet. So we hope that this patient's E antigen is negative and DNA will be negative in the blood. He still has cccDNA and integrated HBV DNA into the genome of the host. So there is a chance that if he is given immunosuppressive therapy or chemotherapy or biologicals, he may activate. So he requires a close follow-up. In terms of dialysis machine, I have already said that this concept is not accepted, and we will have the opinion of Nadeem Tehanmi, what is the practice in UK. The dialysis setup is should be such where all disposables are used only once and disposed of. So there is no concept of B positive and C positive machines. I will also say that please, I still find that the patients are on dialysis or have CKD, surface antigen negative, and have not been vaccinated for hepatitis B. This is another problem which all of you should be very, very careful about, that patients with CKD should be vaccinated if they are surface antigen negative and not being vaccinated as soon as possible. And they should also be followed up with seroconversion and every year antibody test for anti-HBs, because these are immunosuppressed patients, may not seroconvert, may require double dose or may require repeated boosters. So this is another thing that you should keep in mind. I'll stop here. I would first like to have Nadeem Tehanmi to tell us this concept of hepatitis B and C machines, and also whether the dialyzers can be reused or are reused in UK. Ji Nadeem, please go ahead.
Availability of the equipment and under-resourced setting, sometimes we have to accept a compromise which may not be ideal. But I cannot obviously add anything further to what you've said. Can I please ask you a question on the note of this natural immunity when patients develop these hepatitis B surface antibodies? Is there a level that you, in terms of, do you try to quantify? Do you then take that level into consideration when you are offering these patients vaccination, or you don't look at the level and just offer vaccination to every individual who has seroconverted, that is lost surface antigen and has or has not developed surface antibodies yet?
Excellent question, Nadeem. Normally, these patients should be tested because they are high-risk patients. As I said, because of practices in the dialysis room are not perfect. and there is risk of spread. So they should be kept with anti-HBs level of more than 100. And if they are not there, despite vaccination, you need to either repeat the vaccination with a double dose, or you can give a booster and see the antibody levels after 6 weeks to see which way things are going. So yes, these patients should have anti-HBs monitoring along with HBsAg and anti-HCV monitoring on a yearly basis to decide the need for booster doses or revaccination so that the vaccine remains effective and it does not, the immunity may not wane off with time, and they may be at risk of getting hepatitis B. So this is the population. Dialysis patients are a population where I certainly would recommend anti-HBs monitoring, maybe on a yearly basis, to see the response to previous vaccination and make decisions based on that. Thank you.
Dr. Altaf, thank you very much. Very quickly, if you can go through the first question about a patient being worked up for dialysis and what investigations. We know he is surface antigen positive and core antibody, probably IgG positive. So I'm just very quickly for the audience and then we move ahead.
I would certainly like to do hepatitis B E antigen, which, as I said, should be negative, to fit them into the category of functional cure and complete cure, etc., etc. So I need hepatitis B E antigen. This patient is 45. Remember, any person who has been exposed to hepatitis B is at risk of HCC without having cirrhosis. Ultrasound has been done, so that is very good. Maybe you can add alpha fetoprotein. As I said, there is a category called occult hepatitis B, and one should not be swayed by negative surface antigen. One should always document a negative HBV DNA, because in occult hepatitis B, with this picture, DNA may be present, So these are minimum investigations which should be done. As surface antigen is negative, I would not ask for delta because it does not survive without surface antigen. Of course, anti-HCV should be checked both, and HIV should be checked. And one should also look at the whole liver panel and blood counts, etc., just to make sure that all other parameters are okay. I'm not going to go into the tests which are needed for renal failure because there are many, including biopsy. So I would not go into that, and we will get the help of nephrologists to sort that problem out and do the needful there. So thank you. This is all I had to say about this.
I'll just take a few more minutes. I can see if I can pick up correctly. We have Sheikh Zaid, Asif Zadi here, Faisal Hanif, I can see the name from Bahria probably, and Saleh, if my guess is correct. So I'd just like to know what's happening in Sheikh Zaid on this and about the dialysis center and spread of infection and probably Shafa and Bahria. Asif, you like to chip in? Asif Zadi.
Assalamu alaikum.
Ji, please go ahead.
Sir, actually, we have a very good unit, and we do not reuse anything like these dialyzers and etc. So, but yes, we have a different machines like hepatitis B and C machines. We're still unable to tell them that they could be probably this concept of different machines are there, but they are having a different. They are using different data. So they are in that sense they are on the right path. This is the situation.
थैंक यू अल्ताफ साहब ये फिर कन्विंस नहीं कर सके कोई बात नहीं साले you have anything to add
Thank you, Dr. Asad.
welcome pleasure to see you ji Saleh please
Sir, Assalamu alaikum.
Assalamu alaikum.
Sir, I would add one thing that at Shifa we do not reuse these dialyzers, and everything is disposed of as per the recommendation. I would add one more thing, that it's that honey being of these people around in the dialysis room who would spread these infections rather than the machine spreading the infections. So we do honey being, and we are careless, and it's basically not sort of. I think I have talked to people here as well and could not convince them. But what they say is, by separating or segregating these machines, they have sort of separating these stations, so that those technicians, they are working on those machines for the rest of the day there, or for the rest of the shift there, rather than going to the other bay and rather spreading it to more than to more people. One more thing is that I also asked them that if it is the antibodies would take more longer to appear, rather than, and probably that machine is, as people would say, that is already infected, but the machine is not infected. It's basically the station or the bay which is being sort of reserved for these patients, so that these patients or their attendant technicians, they do not go into the other bay. One more thing is that I would also emphasize one more thing, that unfortunately, these technicians are at times so careless. Professor Altaf would agree that many of them would get infected from hepatitis C while working there. So they are not following those recommendations. And unfortunately, one more thing is that I do agree with Professor Altaf Alam that at times I would say that I have seen one patient this week, and unfortunately, he was not vaccinated while he was on dialysis for more than 3 months or so.
Ji Asad,
Hello.
over to you.
ji Faisal Dr. Faisal Hanif are you with us you can then quickly add something
Assalamu alaikum, sir. Sir, actually, I am a trainee, sir. I am not the
it's okay
I am a
if you,
trainee.
if you have any question then I was just confusing you with Dr. Faisal
Yes,
of Baria so it's okay thank you
no,
welcome
sir.
welcome to this forum there's a question in the chat is hepatitis B treatment indicated if patient has occult hepatitis B and which patient should be tested with HPV DNA if surface antigen is negative?
Well, it's a very difficult question to answer, but generally speaking, a patient with chronic liver disease, either based on imaging or biochemistry, who has been tested for all other possible causes of liver disease and all are negative, but anti-HBC, IgG, and anti-H and or anti-HBS are positive, then these patients should be tested for HBV DNA by PCR in blood. But having said that, they may still be negative for HBV DNA. And if you do a liver biopsy, then you can detect HBV DNA in the liver or in any other tissue that you happen to take a biopsy. So it's a difficult condition to diagnose. There is no guidelines on how to treat it, but generally speaking, if I have excluded all other possible causes of liver disease, which may be metabolic, viral, autoimmune, hereditary, and if the patient has anti-HBC or anti-HBs and DNA is positive, I would certainly treat. But if the DNA is negative, I would not be, on a personal note, I will not be treating these patients, because in my opinion, if the DNA is negative, you are, you will be treating unnecessarily, because you want to kill the DNA or suppress the DNA, and if it is not there, I would certainly not treat.
Thank you.
In occult hepatitis.
थैंक यू सर. मेरे ख्याल में इट्स टाइम कि हम अपने डायलिसिस सेंटर की भी एक स्टडी करें and maybe we pull in data to see what's going on. Any other question on this topic? Then we can quickly move on to the next case.
एक क्वेश्चन मुझे चैट में नजर आ रहा है कि decompensated chronic liver disease should be treated with nukes if surface antigen is positive and DNA is negative. So again, a very good question. And on a personal note, I believe, and many experts believe, that if you have effectively excluded all other possible causes of liver disease, and you have a patient with cirrhosis or decompensated cirrhosis, surface antigen positive, DNA is negative, one would be inclined to treat. It is just like, I'll give you an example. This is just like treating an immunosuppressed patient who is getting, immunosuppressed because of anything like high dose steroids, rituximab, chemotherapy, biologicals, etc. And surface antigen is positive and DNA is negative, you are treating. So I take it that way, that, cirrhosis is also an immunosuppressed state. And if surface antigen is positive and you have effectively ruled out all other possible causes of liver disease by all the blood tests available, then, or maybe with liver biopsy as well, we could certainly make a case to treat despite DNA being negative. Although there are no guidelines on that. Thank you.
Thank you. Thank you very much, Dr. Altaf. So we have another 30 minutes. So we move on to the next case. Is there any question? Ji, Dr. Junaid, welcome. Good to see you.
Thank you very much, sir. From Dr. Altaf about the last comment that he made. How long would you treat this patient? I mean, he's already DNA negative. E antigen wouldn't be very supportive here. So how long would you treat this patient?
Well, in a cirrhotic or decompensated cirrhotic, if I'm treating hepatitis B, it is forever. Or until the transplant, and then continue the therapy after transplant, and then see how things go until the surface antigen becomes negative, maybe. So lifelong.
Most likely.
Okay, thank you. Uzair, if you can share the second case. आप इसको थोड़ा सा enlarge कर सकते हैं स्क्रीन को अपनी. Okay, so this is a patient. He's 35 years female with generalized body pains and itching all over the body for 1 month. She has had a C-section 1 month ago. So on examination, a patient has jaundice, pallor, abdomen is soft, a little bit epigastric tenderness. Medical history is otherwise insignificant, and there's no family history of liver disease. You can see the investigations here. Hemoglobin is 10. white cell 9.1, platelets are good, creatinine is normal, bilirubin is 2.9, ALT is 384, AST 238, ALK phos 230, albumin is 3.8. Blood sugar was not available, surface antigen negative, and anti-HCV is positive. There's an ultrasound abdomen done, which is reported normal. So the questions are on about the breastfeeding in this case, further investigation and management. So, Dr. Altaf.
Right. Should she continue to breastfeed? The answer is yes, as we have clear documentation in the guidelines that these patients should continue to breastfeed. The risk of transmission through breastfeeding is negligible. And even if it does happen, the effective treatments are now available for use in children, and we can certainly go on to that. So for breastfeeding, it is a very clear answer. I would like to expand on this, that there are two more things. Whether you should, about oral contraceptive pills, or which type of contraception these patients should have. Well, generally speaking, they can have all types of contraceptive pills. It is a myth, not a fact, because the estrogen content is so low in the currently available treatments that there is no problem even with cirrhosis or decompensated liver disease. So breastfeeding and contraception go side by side. So, I would just like to add that. Any comments or any questions on this aspect alone, breastfeeding and contraception?
Sir, this in this specific case, do you think we like to roll out hepatitis A and E also, and then make some point on breastfeeding?
Yeah, we would certainly, if coming to investigations, we would certainly like to do a few things. What are those things? You have to think about cholestatic syndromes. You have to think about other viral hepatitis like A or E. Cholestatic syndromes, it is recommended by Royal College of Ops and Gynae that any patient with ICP should be followed up at 6 weeks for abnormal or normal liver function tests. If their liver functions are abnormal, then they should be investigated further for cholestatic diseases, particularly primary biliary cholangitis and sclerosing cholangitis, etc. I'm not bringing in cholestatic syndromes due to genetic mutations in specific genes as a cause. So, this is another topic. So I will not bring it into that. So in terms of investigations, we would certainly like to do screening for autoimmune and primary biliary cholangitis by asking for autoimmune liver disease profile. Ultrasound is normal, but if I'm stuck up at the end, then certainly MRCP and liver biopsy come into play as well later on. So A, E, HCV RNA by PCR, and autoimmune and PBC profile should be checked in this particular patient before we decide any treatment. So if I've missed any investigation, you can point out or bring it up and we can discuss that. Any comment on this?
Saleh, would you like to add anything?
I will just agree with Professor Altaf for the time being, and I think we should move on to the rest of things because the other two questions are quite interested.
Okay. Dr. Altaf, I think we move on to the management of this patient. Breastfeeding पे आपने बात कर ली, तो management में जो एक सवाल होगा वो ये भी होगा कि during breastfeeding we are going to treat her or not. So first, so please,
So how should we manage this patient? Should we address this question now?
Yeah.
Okay. Well, I'm not in a hurry here. I've done the basic investigations. All are negative. C is positive. PCR turns out to be positive. There is no evidence of autoimmune or cholestatic syndromes. So I would not be in a hurry to treat hepatitis C. I know I can get 100% results with normal liver whenever I treat this patient, and she's not going to develop cirrhosis in 1 year. So I would encourage her to come back if once she has stopped breastfeeding, and I could start treatment at that time. Now the question arises, what is the effect of these drugs that we use, like soft Tecla and soft Velpa, on the infant who is being breastfed? So the answer is not been addressed so far. So there is no clear data. The safety of these drugs is not established in pregnancy and breastfeeding. But having said that, there are pilot studies of treatment even in pregnancy. So they which show that they are safe. But as I said, on a personal note, I'm not in a rush, and I'm not worried about treating this patient immediately. So I would advise her to come back after once she has stopped breastfeeding, maybe 3 months, maybe 6 months, maybe 12 months, or maybe 18 months. And then I will recheck HCV RNA PCR. Now, there was a question there that there is 10% spontaneous resolution in hepatitis C. Well, yes, that is in genotype 1 and 4. In genotype 3, there is up to 29% spontaneous clearance rate. So I would, whenever she comes back, I'm going to recheck for hepatitis C RNA before deciding on treatment. In terms of this treatment, this patient, this may be acute hepatitis C if all other tests are negative in cholestatic phase. So you can treat on the lines of cholestatic phase of acute hepatitis C and hope that that will take care of the symptoms that the patient has. And of course, with time, whatever the virus you are dealing with, the cholestatic syndrome, the cholestatic symptoms settle down with or without treatment. So you can use various treatments that you have in your armamentarium, including ursodeoxycholic acid, rifampicin, antihistamines, even steroids, not in hepatitis C, but I've certainly used them in hepatitis A and E in cholestatic phase. Remember that if things are not settling, the bilirubin is rising, think about genetic mutation. I've done it in 2 patients. It is done in Pakistan, costs something like 3 to 4 lakh rupees. But ABCB4, ABCB11, and ATBB7 genetic mutation can be done. And if that mutation is present, rifampicin within 4 to 6 weeks gets rid of all the jaundice and cholestatic symptoms. So think about that if you are confronted with a patient who is not resolving, and you think it could be persistent hepatocellular secretory failure, as we call it, due to these genetic defects. So one should think about that. But in this case, I would not be in a rush to treat and call her back when she stops feeding.
डॉक्टर अल्ताफ, इसमें ये गालबन हमारे ट्रस्ट का केस है और obviously affordability के भी इनके issues रहते हैं. The question is, if we have ruled out other causes, genetic mutations, so we can leave aside, but A virus, E virus, core IgM, usually what we do. क्योंकि 1 महीना पहले she had C-section. I couldn't find के blood लगा नहीं लगा, और acute hepatitis C की जो picture बन रही है, it's very rare for acute hepatitis C, or it doesn't cause that often. जो acute picture इस तरह की है, इसमें आप कितना wait करना चाहेंगे, and if the results do not settle, how anxious you would be in starting a treatment? Let's say bilirubin, after 6 weeks, it's still around 3.2, ALT is high, it's not come down that well, and we have ruled out other causes of hepatitis. तो उसमें फिर treatment, और क्या हम उसको breastfeeding stop करने का कहेंगे, or we can start treatment, please?
Short of checking for genetic mutation, you can certainly try that by requesting the patient to stop breastfeeding and start the treatment for hepatitis C if it is still positive at 6 months and the liver functions are abnormal. So certainly one can try that. There is no contraindication on when to start treatment based on the liver of bilirubin in hepatitis C. So, in acute hepatitis C, in the European registry, they treated even with bilirubin of 20 with acute hepatitis C with DAAs, and within 8 weeks got 100% SVR in all patients, around 80-90 patients that they had on their registry. So yes, short of genetic testing, one can do that. In terms of which lab is doing that, I have talked to labs, and to my knowledge, IDC is doing all the genetic testing if you ask for. They are sending the samples either to USA or Germany, and they are doing all types of genetic testing. Previously, I had a talk with Excel Lab as well. They offered to do all these genetic tests for hemochromatosis, and for Wilson's disease, and for cholestatic syndromes. So these are the 2 labs to my knowledge. But once I talked to Chughtai's lab as well, and they said if you send the samples, they can also arrange that. So these are the labs which can help you in getting these tests done.
Okay. Any other question or comment? We still have about 10 minutes also.
Can I say something?
Yes, Salim.
One comment and one I'll say something about this genetic testing for these cholestatic mutations, or that one of our previous person who is currently working at NUMS, who is a PhD doctor, geneticist. So I think acute hepatitis C is never an emergency unless and until it's a fibrosing cholestatic hepatitis C. And for that, we have a definite certain criteria. So I would agree, Professor Altaf Alam, that you can wait for that, and at least 6 months or 18 months or 12 months, whichever the parents or the mother would like to wait for. And then one can treat him. One is in a rush, is fibrosing cholestatic hepatitis C. And for that, you need a few things before you label that.
Thank you, Saleh.
Thank you. There was a question in the chat. Saleh answered that on the guidance to manage acute hepatitis C. Any other comment or question on this?
Yeah, acute hepatitis C, you treat for 8 weeks with all the available pan-genotypic drugs, and you get 100% SVR. So you can use SOF-well, you can use GP, and you're likely to get 100% response rate within only for 8 weeks. Ji, Nadeem, you have raised your hand, so please go ahead, Nadeem.
So it's a question to you and Saleh. The question is, as I said, please excuse my simplicity. It may sound very simple, but what makes you think that this is a case of acute hepatitis C? I'm sorry, I might have missed some important information. And also, what was the ICP, and did she get better or improve post C-section or not? So if you could
Asad
please
is
elaborate.
going to tell me about the patient. It is his patient. So did she have ICP during pregnancy, itching during the second or third trimester?
We don't have any history of that, Dr. Altaf. और हमने तो उसको गालबन स्केबिस का ट्रीटमेंट भी दे दिया.
Very common. So what makes us think that this is acute hepatitis C? Certainly on the data given, we cannot say that. So you have to rule out all other possible viral, autoimmune, and cholestatic diseases before you can say for sure that cRNA is positive. There is no other cause that we could find, including the liver biopsy. Then one can very safely say that this is probably acute hepatitis C. Of course, there are always some gray areas, but one has to rule out all other possible causes. Thank you, Nadeem.
Dr. Junaid wanted to say something.
We have time, so I just wanted to ask Professor Altaf about the comment that he made. He said that he has treated patients with A and E in cholestatic phase with steroids. Wouldn't treating hepatitis E with steroids cause immunomodulation, and maybe they can go on to chronicity after that?
Fortunately, fortunately, the genotype that we have does not persist in the body. We have genotype 1, 100% genotype 1. It does not persist in the body. It does not cause chronic disease. It does not cause extrahepatic manifestations except pancreatitis. So we have everything in favor. So you can treat. But as I said, there are other options. One is always very reluctant in giving steroids. I take your point, or for that matter, even rifampicin in these patients. But I can tell you that it is all based on ruling out all other possible causes of liver disease. And I have treated a patient with genetic mutation whose test was taken, and he was started on rifampicin. Within 6 weeks, his bilirubin from 60 came down to a single figure. So with rifampicin. So starting with 150 and increasing to 300 and even going up to 600 a day. So, and later on, his genetic mutation ABCB11 came back as positive. So, he had no other cause. He had an acute hepatitis, everything settled, but because of genetic mutation, bilirubin was not coming down. So that is besides the point, but yes, I have used steroids in selected cases with careful monitoring and careful follow-up. If ursodeoxycholic acid or cholestyramine is not working. Yes. Saleh, do you have to Nadeem's query or to Junaid's comment? Do you have anything to say, Saleh?
Sir, I have not given steroids to any of my patients. I am a bit on the conservative side, and but luckily, I would say that I am not faced with that much difficulty in dealing these patients. One, and I think once or twice. The other thing, usually their antibodies may be negative, and when you see these patients, and at times we do check for an cvRNA that is positive, and of course these patients would have an antenatal checkup available to us, and they would have a negative anti-CVA as well, and maybe there is a history available to us, and I have so far treated only four patients with acute hepatitis C. That's it, and it's a particular clinical scenario that these patients would fit in. The other thing is that I would also consider in this patient because she had this cholestasis and the purpura, and may start after the delivery even. So if you don't have a history before that, so one would still like to consider that. Probably Professor Altaf Alam may elaborate onto that. Over to you.
Any other question or comment? There is something that came up that there are certain predictors of response or spontaneous resolution in acute hepatitis. Yes, theoretically they are right, but in the era of DAAs, there are no predictors of response or no response. You treat as early as possible according to the indication and with the appropriate drugs, and you are likely to get 98 to 100% response rate in non-cirrhotics. So yes, I agree there are certain predictors of spontaneous resolution, but in the era of DAAs, they are irrelevant and nobody bothers to look for them and believe that these patients are going to clear spontaneously or not. You just treat them all whenever you can catch them. In the Western world, they are mostly the patient who are IV drug addicts, and nobody would take the risk of letting them spread to other people while waiting for spontaneous resolution. So in the West, there is a trend to treat them all whenever you can catch them and treat them as early as possible. Thank you.
जी सर, very quickly ये chat में चल रहा है about vaccination for hepatitis B. We check this in all the patients, and we offer them vaccination no matter what, or अगर doubt भी हो तो we still go for vaccination of hepatitis B anyway. And what about her husband? Do we need to check him? And if yes, do we need to check? I think we encourage in the spouses of all the patients, male or female, even family, especially in our, I think in Sheikh Zayed or all the public places and public institution, like in our Parsa Trust where we have liver clinic, so we offer it to all. This is one question about direct and indirect bilirubin interpretation. I don't know whether it's in the context of this case. Unfortunately, I don't have the exact values apart from a total bilirubin of 2.9. Dr. Altaf, can you quickly comment in this context of acute hepatitis, how important will it be, direct and indirect bilirubin?
Yeah, it is important because I always tend to look for it, and it is really a pity that with raised bilirubin, certain labs are not splitting it into direct and indirect. Even seeing a bilirubin of 10, they would just say bilirubin, ALT, AST, etc. So, the labs should always give direct and indirect. And as you know, in a hepatitis picture, they both are elevated. But as the cholestatic phase progresses, it is more of conjugated than unconjugated, or more of direct rather than indirect. But certainly looking at them will help you in your differential diagnosis, and you would probably not miss other causes.
You said your last question about husband who comes on this patient with hepatitis C. Husband is tested negative on screening. What advice you give to the couple about safe sex?
It's standard. The spread through sexual route, I mean, not homosexual, but heterosexual route is minimal, and we do not advise any precautions in hepatitis C. It is different in B. We ask them to practice contraception until the partner is vaccinated completely and seroconversion has been checked. So in C, one can continue to have normal sexual relationship.
जी, एक और आखिरी क्वेश्चन है about E antigen negative patient who is in immune reactive phase of hepatitis B, where our goal is loss of surface antigen. So how realistic is to achieve this goal? How many patients do we achieve this goal?
Right.
A quick comment, Dr. Altaf.
0. So in E antigen negative disease with nukes, we hardly ever get surface antigen negativity. So it is either lifelong treatment, or according to the guidelines, you can, after 3 years or 4 years of viral suppression, you can try to take off the treatment and hope that immunity will take over. So thank you.
Thank you very much indeed. This brings us to the end of this program today. A very informative session, and I'm extremely thankful to Professor Altaf Alam and a lot of senior person here. I can see Dr. Zaid Bhatti here, Junaid Saab joined, Nadeem and Saleh. And I would like कि आप दोबारा join करें. So we have a lot to learn from each other. So it's a real pleasure, to see all of you here. On behalf of PARSA Trust and our ECHO program, I'd like to thank all the participants, especially grateful to our team at PARSA Trust who are working very hard for this program in Pakistan. Uzair, Kiran, Amna, our IT people. And last but not the least, I'm indebted to Frozen's Pharma for their support for this program, which we need to keep running these programs. So I think our next program will be on World Hepatitis Day. We'll be talking about hepatitis elimination. Uzair might be sharing that. And then we have some other programs lined up, inshallah. And I also want that this is in special collaboration with Pakistan Society of Hepatology. Our annual conference is coming 22 to 24th of September in Lahore. So please mark the date and keep yourself available for an exciting meeting, inshallah. It will be in-person meeting, and we are expecting a lot of big names from all over the world, to teach us. So thank you very much, everybody. Allah Hafiz. Uzair, you can call off the meeting.
Sure, sir. Thank you very much. Allah Hafiz.